This next group of drugs are classified as the DPP4 inhibitors, and basically what they do is there's two targets here that you have to be aware of, and GLP is the next one, so we'll talk about both of them. So under normal circumstances, we'll start with GLP1. GLP1 stimulates either insulin secretion or suppresses glucagon secretion. That's under normal circumstances. DPP4 enzyme, under normal circumstances, inactivates GLP. So what we do is we supply a DPP4 blocker to preserve the activity of GLP. So we want to keep GLP active. We want to inhibit DPP4. So that's the kind of the therapeutic strategy here. So we'll come back to that mechanism a little bit later. So what are the medications in this class? Well, first of all, DPP4 stands for dipeptidyl peptidase. And there's really three medications in this class. They're all of, I call them the gliptins. They end in gliptin. And they inhibit that enzyme, dipeptidyl peptidase. And of course, by doing so, that prolongs the half-life of GLP. And that leads to a decrease in postprandial glucagon release and an improved increase in glucose-dependent insulin release. So the target population is really those patients that experience post-meal hyperglycemic episodes that really don't want to take insulin. They don't want to give themselves injections. And the primary target is really those insulin or those glycemic surges that are accompanied after each meal. And so, of course, the site of activity here for these DPP4 inhibitors is kind of within the GI system in the gut. And they have modest efficacy on reduction of A1C, up to 1%. The adverse effects are relatively rare. Stevens-Johnson syndrome, facial edema, hives or itching, and possibly pancreatitis, although not quite often seen. And so comparing their advantages and disadvantages, there are several advantages. They're basically well tolerated. They don't produce hypoglycemia like some of the other drugs. And they don't really offer weight gain. So these are pretty good reasons to prescribe these. The more disadvantage include cost, a modest efficacy in terms of a reduction in A1C, but there are rare but serious adverse effects if they do manifest themselves. So kind of going along with this are the GLP receptor agonists. And the drugs in this class are listed here. They all end in tide. Interesting story. The first one, exenatide, was actually extracted from the venom of the Gila monster. And then all the drugs were basically modifications, chemical modifications of that parent compound. So these are agonists at the GLP1. And so what happens here is you're going to see a reduction in the degradation of GLP1 by DDP. Okay, so it's going after the enzyme. You can see an increased glucose-dependent insulin secretion. You can see reduction in glucose secretion after meals. And also you see GI effects too. You can see a slowing of the gastric emptying time, and the patients will feel fuller faster. So the target population, of course, would be your overweight population, but willing to use injections. So these are the only ones that are injected in this category. The primary glucose target here is that, postprandial or post-meal surges, but you can also use these two drugs, liraglutide and exenatide, extended release, for patients who experience fasting, so patients who maybe don't get to eat during the day. And of course, the same site of activity within the GI system. The efficacy is about the same as the other category, a reduction of A1C by about 1%. Nausea and vomiting are more common with this drug, as well as pancreatitis. And as I said before, these drugs are delivered subcutaneously. There's kind of a specific product information sheet in terms of how to dose this. You can see doses of of insulin secretagogues. They might have to be decreased when these drugs are co-administered, and so you might have to see a reduction in something like metformin or something, or glipizide, when you co-administer these GLP1 agonists. And so from advantages, disadvantages, comparison, we can see there is a weight reduction as an advantage for some of these drugs. You don't really see hypoglycemia. And from a physiologic standpoint, and this is not really quite understood, you can see kind of an improved functionality of those beta cells within the pancreas. Of course, from a disadvantage standpoint, they're costly. There are some GI adverse effects. This is injection, of course, so some patients don't want to do that. There's really not that much long-term data. We don't really have a lot of patients staying on these drugs for long periods of time. And of course, this constant threat of pancreatitis kind of still looms. Okay, so that's the DDP and the GLP1 drugs that kind of go together. So we will end this lecture right here.